Good evening, everyone. We'll be starting shortly. Just one moment, please.
Good evening, Dr. Cole. Good evening, everyone.
Good evening.
Dr. Cole, please, can you enable screen sharing?
Yes, I'll do that right away. Are you able to share your screen now?
Let me try. Okay. This is the screen. Share. Are we able to see the screen, please?
I think it's coming up. It's coming up gradually.
Okay.
Yes. Good evening, everyone, and welcome again to another webinar series for the Skin NTDs. Maybe we'll wait for a few more minutes to have more participants join in, and then we'll start. You're welcome, Dr. Oyewol.
Thank you, Dr. Cole. Welcome, everyone.
Is my screen on?
Yes, your screen is on. We can see your screen. We'll just wait until 4:30, 4:35, and then we'll start. So thank you everyone for joining in. For those who have joined in previously, just to let you know that the previous webinars are on the YouTube. You can access them via YouTube. I will put the link in the YouTube in the chat box during the course of the meeting. If you had missed any of the previous webinars, we had leishmaniasis, and then we had onchocerciasis. So it'd be nice for you to go through. We're going to have a end of webinar evaluation and also attendance. So people who make up to 60% of the attendance are those that will receive certificates at the end of the webinar series. So if you have missed any of them, you can actually go to the YouTube channel to catch up, and this will also be uploaded there as well. Thank you. So I think we can actually start. It's 4:32, and I think we can kick off the webinar from now.
Okay, I'm coming, I think. So good evening, everyone. Well, welcome to another session of our discussion on skin-related neglected tropical diseases. Our topic of discussion today is Buruli ulcers, and as previously done, we will, okay, my slides, what's the problem? I'm coming, please. Okay, so this teaching series holds twice every month. My name is Dr. Nafisa Abdullahi. I'm a consultant dermatologist and venerologist with Federal Teaching Hospital, Katsina. And this is brought to you courtesy of Nigeria Association of Dermatologists, the International League of Dermatology, and International Foundation for Dermatology. We will be following this outline: introduction, microbiology, epidemiology, clinical features, management, complications, and prevention. So as the way of introduction, Buruli ulcer is one of the neglected tropical diseases that is mostly found in sub-Saharan Africa. It's also found in some parts of Australia and also in Asia. It was first described by Albert Cook in a paper that is referred to as that's called the Mengo Hospital Notes. It was first, a lot of cases were later found in a place called Buruli in Uganda, hence the name Buruli ulcers. About 50 years after Albert Cook described this disease, McCollum and colleagues described it in a place called Barnsdale in Australia. Hence, one of the synonyms of Buruli ulcer is actually a Barnsdale ulcer. But what was common to all the patients that were described both by Albert Cook and McCollum was that all the patients had chronic leg ulcers. It is caused by Mycobacterium ulcerans, and Mycobacterium ulcerans is actually the brother of Mycobacterium tuberculosis and also Mycobacterium leprae. All of them are acid-fast bacilli, and they are all referred to as the mycobacteria. So it is mostly found in areas with water bodies, mostly common in areas that have water bodies, and is the third most common mycobacterial disease after leprosy and tuberculosis. The duration of illness is usually long, and sequelae usually can be a cause of serious disability, as we'll come to see later. The disease can last months, the ulcer can last months to years. Hence, it is one of the causes of a chronic leg ulcer in patients. Now, as I mentioned earlier, Buruli ulcer is caused by Mycobacterium ulcerans. And this Mycobacterium ulcerans, like the other mycobacteria, is a slow-growing mycobacteria, but it actually optimally grows to around 29 to 33 degrees. And this is thought to explain why it has predilection for the skin, because the skin is actually cooler than the other organs in the body, which are usually at a higher temperature. So this optimal temperature of its growth, 29 to 33 degrees, is thought to account for why it has predilection for the skin. It is an acid-fast bacilli together with Mycobacterium leprae, Mycobacterium tuberculosis, Mycobacterium. There are many other mycobacteria. All of them are acid-fast bacilli, and other also non-mycobacterial acid-fast bacilli. This is important when we talk about the staining for samples of patients with Buruli ulcers. It is unique amongst other mycobacteria in that it produces mycolactone, and this mycolactone is thought to account for the reason why the patients come with ulcers. So it is thought that once the bacteria enters the body, it starts secreting this mycolactone, and this mycolactone is actually it causes necrosis of the skin and the subcutaneous tissue, hence the resultant ulcer. Now, this mycolactone, you have different types. You have the A, B, and the C. The A and B is what is found in Africa, while the C is found in Australia and parts of Asia. Up till now, there is no known vector for the transmission of Buruli ulcer. In fact, the transmission of Buruli ulcer is one of areas of intense research because it is not known how it is that it gets to human. But what has been shown is that there are very, very, very rare instances of human-to-human transmission, and mostly it is between the humans and the environment. And like I mentioned earlier, it is found in areas that have water bodies. So whether there are some organisms within the water that's transmitted to humans or not, it has not yet been elucidated. So this is an important point when it comes to issues of prevention. There is no vector, so vector control is not one of the ways of preventing Buruli ulcers. The exact figures about the number of Buruli ulcers are actually lacking. This is, like I mentioned, found in Africa, Australia, and parts of Asia, but Africa takes the huge chunk of it as usual. We have more than 70% of cases reported in sub-Saharan Africa in particularly. And Nigeria is actually sandwiched between Cameroon and Ghana, where the patients, a lot of cases are reported. Australia also, and then parts of Asia like Japan. It is more common in children aged 5 to 15 years, and is mostly a disease of the poor and the lower socioeconomic class, mostly found in areas with water bodies close to them. Now, this is a graph that is attempting to show, sorry, please. This is a graph that is showing the burden of Buruli ulcers reported in the year 2020. We can see it's from the Global Health Observatory of the WHO, and about 1,458 cases were reported. If we look at the pattern, there were a higher number of cases reported in 2012 compared to 2020, which suggests, this is a suggestion, that Buruli ulcer cases are actually declining. This may be true, but the other explanation could be that there are more cases that are being missed. They are not presenting to the hospitals, or even when they present to the hospitals, they are not diagnosed, or even when they are diagnosed, they are not reported. The next slide shows the report of the number of cases by country from 2002 to 2016. If we look at Nigeria, which is around here where my cursor is showing, you see ND from 2002 to about 2008, which means no data. It doesn't mean we don't have the cases, but it means no data, except for 2006 where we reported 9 cases. But then we picked up in 2009 and we started reporting up until 2016 where we reported about 235 cases of Buruli ulcer. This second slide picked up from 2017 to about 2020, and this sorry please. And this shows report Nigeria is second to the last, and we reported about 231.50 and then 943. So this is the number of cases that have been reported. This does not say the exact number of cases of Buruli ulcers in Nigeria. These are the number of cases that were reported. Now, when we look at again in Nigeria, where have we had reports from Buruli ulcer, we find that it was first reported in 1967 among the Tiv in Benue and also the Bambor tribe in Adamawa State. It was also reported among Caucasians living in the campus of University of Ibadan, and they are known to be swimming in artificial lakes. Another 10 to 15 cases were reported by the TB and Leprosy Hospital in Cross River State, and another 43 cases from Enugu and also from Ebonyi State. There are also cases of many Nigerians seeking help treatment for Buruli ulcer in neighboring countries such as Benin Republic and also from Ghana. And there was also a study in 2006 which attempted to confirm the suspected Buruli ulcer cases in Ogun State. And this number of cases, so 37 number of cases were actually sent to Germany, and then they found that they had 9 active and 5 inactive cases. So there are just some few reports here and there about Buruli ulcer. We don't have a lot of robust data from Nigeria about Buruli ulcer. So how does Buruli ulcers present? This is just the typical presentation. They might present with nodules, they might present with plaques, they might present with edema, and they might present with ulceration. However, because most of our patients present late, majority of them present at the ulcerative stage. If you can catch them early, you can catch them at the nodule stage or the plaque stage or the edematous stage, but generally they present late and they usually present with ulceration. The typical patients with Buruli ulcer, they run at indolent course. It takes a long time of dealing with the disease, seeking help here, and it can take months to years of moving around with an ulcer. In the beginning, it may start as a single or multiple nodule that is usually less than 5 cm in diameter, but gradually the nodules will coalesce and then they become ulcerated. Typically, it involves the limbs, but at times you see it in the neck, the face, and even the groin region. Rarely, it may extend to involve the underlying bone tissue, but this is a rare case. And when they heal, they can heal with contractures and cause severe disability and also disfigurement of the patient. These are just pictures. Sorry, I know these pictures are not nice to see, but it drives home the case that we're trying to make. That imagine if you are watching this and you don't want to see this, imagine the person who's having to live with this ulcer without help or without knowing where to seek help or seeking help repeatedly from people like us, but we do not know what to do for the patient. So these are patients that have ulcerative stage of Buruli ulcer. But if you look down here, the picture on your bottom right, you can see an edematous hand, and this is an edema stage of the Buruli ulcer. All these pictures are actually courtesy of up to date. They are not my personal pictures. These are now pictures from courtesy of our state chapter of the National TB and Leprosy Control Program. These pictures are actually patients that they picked and they are managing. That is in carcinal state. And these are pictures of patients with Buruli ulcer. We can see the ulcer involving the lower limb. We can see the ulcer involving the lower limb here of the patient, another patient here, another patient. If we observe, most of these patients that we are saying we're showing are actually adults, as against what is known that mostly it is children. But we have a young girl here who presented with an ulcer on her knee. When she presented to them, these are not patients that I manage, but when she presented to them, she presented with, she was wheelchair bound. But this is when she came for follow-up on treatment, she's better and she was able to walk even though with a limp. So these are pictures of patients from Nigeria with Buruli ulcer. These pictures that we are showing here. Now, how do you stage Buruli ulcer? After looking at the patient in totality and looking at the size of the ulcers, the WHO actually came up with a staging system where patients are categorized, and this categorization have management implications. So category 1 are patients that have single nodules, and they may be plaques, they may be ulcers, and they are usually less than 5 cm in diameter. Category 2, they have single plaques and ulcers that usually range between 5 to 15 cm in diameter, or patients with edematous lesions. While category 3 have single plaques on ulcers greater than 15 cm in diameter, or they have multiple lesions, or they have joint involvement, or they have osteomyelitis, or they have any lesion present at critical sites such as the genital organs, the head, or the neck. So this is how the patients are categorized, and these have management implications. Now, the WHO actually has some case definitions to share with us. They said that a suspected case is a person presenting with a painless skin nodule, plaque, or ulcer, living or having visited a Buruli ulcer endemic area. While a confirmed case is a suspected case that is confirmed by at least one laboratory test. This is relevant. We'll see just in the next few slides. You can do Zilnelson, you can do for AFB, you can do PCR, you can do culture, or you can do histology. And this is what the next slide is talking about, how to diagnose patients with Buruli ulcer. Like I mentioned, smear examination, culture, histology, or polymerase chain reaction. Now, this smear is the most readily available diagnostic modality. We have a lot of people at the different cadres of the healthcare workers that are able to do an acid-fast staining for acid-fast bacilli. Mostly, you can even access this staining even at primary healthcare levels, at secondary healthcare levels, and also at the tertiary healthcare levels. So this makes it the most readily available investigation that you can do for a patient with Buruli ulcer. It involves staining of the ulcer fluid for acid-fast bacilli, and what you do is that you swab the ulcer at the edges as much as you can. You go to the undermined edges and you swab from there, and then the swab is taken and is made on the microscope, and then an acid-fast staining is done. If one is able to pick an acid-fast bacilli, it may suggest that it is Buruli ulcer. However, this test is only about 40% sensitive. But this yield can be increased with increasing number of swabs. So if you take multiple swabs, a person that takes 3 to 5 swabs is likely to get results compared with the person who takes a single swab. But this should be taken from the edge. If it is an ulcer, it should be taken from the edge of the ulcer. Meanwhile, if it is a nodule or if it's a patient with edematous lesions, you should take from the middle of the ulcer. Another shortcoming of this examination, this investigation, is that it is not specific for Buruli ulcer. A patient with Mycobacterium, with tuberculosis of the skin can come up with acid-fast bacilli. With nocardiosis, they can come up with acid-fast bacilli. So it is not specific for Buruli ulcers. Now, the next one is to do a culture. Culture can be done for Mycobacterium ulcerans, but remember, we mentioned that they are slow growing. It takes about 6 weeks for you to come up with the results. And in 6 weeks, some of the patients wouldn't even have completed treatment. So culture is not easy to use at point of care, that is in the clinic, to take a decision. It can be used to confirm your suspicion, but it's not easy to use it to determine whether you initiate treatment at that time or not. The same thing, samples can be obtained via fine needle aspiration. That is, you use a needle and then you aspirate. If it is an ulcer, you still go to the edge. While if it's a nodule, you aspirate from the middle, or via punch biopsy. A person skilled that can do a punch biopsy will take samples from from the ulcer or from the nodule, and it will be now subjected to culture. And the same media that is used for tuberculosis is the same media that is used for this, and the transport media is this: the panta, the polymyxin B, amphotericin B, nalidixic acid, trimethoprim, and azlocin media. And once you use this media, then it can be transported at a room temperature. It has a better sensitivity than the acid-fast staining. The sensitivity of culture approach is 60%. Histology has a better sensitivity than both smear and culture. But the major problem with sensitivity with histology is that it requires skilled personnel, both to obtain samples and also to interpret the result of the samples. There are entire states in Nigeria whereby you will not have a dermatopathologist or even a pathologist to be able to read this sample. So it requires a lot of skill and training, and that is not readily available. You might have the pathologist, but you will not have the dermatologist to take the sample, or you might have the dermatologist without having the pathologist to take the sample. So this requires a lot of skills. But if you're able to get the early lesion, that is lesions that are less than 6 months of duration, it may reveal coalescent necrosis, vascular occlusion, hemorrhage, and large numbers of extracellular acid-fast bacilli. But if you get a lesion that is more than 6 months old, then you may have fewer acid-fast bacilli, and then it will reveal mostly granulomas. Polymerase chain reaction actually utilizes a section of the organism, which is this insertion sequence 2404, and that is used for performing PCR for Buruli ulcer. The sensitivity is also equivalent to that of histology, about 80%. But the problem is it is even worse than histology, in the sense that it is expensive and that it is not readily available, especially in our own settings. I asked the TB and leprosy control program, then what do they do with their samples? And they said from Katsina, all the way from Katsina, the samples have to be transported to Anambra, but that is where they have the lab to run PCR to confirm the diagnosis of Buruli ulcer. So imagine that kind of logistical nightmare, moving samples from Katsina to Anambra to analyze them. So this is not readily available, and even where it is available, it is pretty expensive. But another advantage of that PCR has over the other investigations is that it can be used in entomological studies. And when we say entomological studies, these are usually done to study the transmission. They're usually done, they take samples from insects, from mammalian vectors, and then they check to see how is this organism transmitted. Is it found in this insect? Is it found in that mammal? Could it be that is where the reservoir is? That is where it gets to human beings. Is that the vector? So this can be used to do some entomological studies on transmission. That's the advantage that PCR has above and beyond the other modes of investigation. Now, what are the differential diagnoses? If it is not Buruli ulcer, what will it be? As we usually say in dermatology, the differential diagnosis of a disease condition depends on which stage you are getting that disease condition. So if a patient is presenting with an ulcer, a frank ulcer, then what you start thinking of is squamous cell carcinoma, tropical hand ulcer, diabetes mellitus, foot ulcer, venous ulcers, or sickle cell ulcers. Squamous cell carcinoma can actually arise in the setting of Buruli ulcers. Any ulcer that has been there for months to years can actually become malignant, and that may present as a squamous cell carcinoma. But usually you see a lot of necrosis, you see a lot of abnormal growth, unequal growth, and the edges are usually not undermined the way that the edges of the ulcer of Buruli ulcer, the Buruli ulcer is. That can help to differentiate. Tropical hand syndrome, diabetes mellitus, foot ulcer, usually the patient will be a non-diabetic, and they tend to occur on the foot, on the weight-bearing areas of the foot. Venous ulcer tend to occur in the lower 1/3 of the legs or around the medial malleoli, and also patient may have a predisposing condition that will make them develop the venous ulcer, while sickle cell ulcers usually present in the setting of sickle cell disease. While at the nodal stage, it may look like cutaneous leishmaniasis, it may look like lipoma, it may look like mycetoma or an epidermoid cyst. Cutaneous leishmaniasis usually first starts with a nodule also, but by the time it ulcerates, it usually has raised edges compared with Buruli ulcer that has undermined edges. A lipoma usually will not ulcerate, and if one can use the slipping sign of lipoma to help differentiate between lipoma and a nodule of Buruli ulcer. Mycetoma usually they present with draining sinuses and tracts. That helps differentiate it from Buruli ulcer. And then the edema stage of Buruli ulcer, it may look like cellulitis or lymphatic filariasis. And this actually can be differentiated by the presence of pain. Buruli ulcer usually is painless, but cellulitis can be painful. There may be signs of inflammation, but this is not synchronous because if you remember, a patient can have super added bacterial infection, so that might actually make things difficult to differentiate. And then lymphatic filariasis can also present like this. So when you have such patients, how do you treat them? This is the WHO recommendation for treatment of patients with Buruli ulcer. Dot categorization that we used earlier, category 1, category 2, and category 3. So if you have a patient presenting with category 1 disease, then what the WHO suggests is that you use 4 weeks of antibiotic therapy. Such a patient may or may not require surgery. So it depends. But even when they require surgery, it's usually just a simple excision, simple surgery that they require. For category 2, they usually require 8 weeks of antibiotic therapy or plus or minus surgery. Again, studies have been done around this category 2. And what they found out is that some delaying surgery actually may eliminate the need for surgery or reduce the extent of the surgery. So some patients didn't have the surgery, and after they completed treatment and were observed, they actually did completely heal without the surgery. While even those that did not heal, the extent of the surgery was reduced compared with those that had surgery earlier. So the suggestion is that for category 2 patients, complete 8 weeks of antibiotic therapy and then look at the need for surgery. However, some patients may require initial debridement when they present. Category 3 patients will take 8 weeks of antibiotic therapy and also may require surgery, but usually in category 3, they might require reconstructive surgery. It all depends. Usually, most of what I read suggested that patients should complete the treatment, observe them, and then you now look at what you need for treatment. And remember that the plastic and reconstructive surgeons are not readily available. So patients may actually not even get access to the surgery, especially those in category 3. So what these antibiotics that I'm saying, antibiotics, what are the antibiotics that as recommended by the WHO? The WHO recommends a rifampicin-based therapy for patients with Buruli ulcer. Initially, this second one, rifampicin and streptomycin, was the one that was being done. Patients will get injection for a month, daily for a month, together with rifampicin. But that daily injection and together with the ototoxicity of streptomycin actually made clarithromycin a better option. So the first recommendation is that a patient should receive rifampicin and clarithromycin for treatment of Buruli ulcer. Like I mentioned, depending on the stage, it may be for up to 4 weeks, it may be up to 8 weeks, but it has been shown that giving treatment beyond 8 weeks does not really have more benefit compared with stopping the treatment at 8 weeks. So usually it's just 8 weeks. If for any reason a patient cannot tolerate clarithromycin, because a lot of people react to clarithromycin, they come down with vomiting that they cannot tolerate the medication. So then other options may be rifampicin and ciprofloxacin or moxifloxacin. In Japan, the recommendation is to use rifampicin, levofloxacin, and clarithromycin. And then the surgical options range from simple excision, debridement. Some patients may require skin grafting and their reconstructive surgery. It all depends on the size of the lesion and also the location of the lesion. Other things to note in the treatment is that there has been integration of Buruli ulcer into the National TB and Leprosy Control Program. This gives patients access to treatment, and also it means we have better chance at reporting and better chance at controlling the disease. So like I mentioned, those pictures that I saw were actually captured by the National TB and Leprosy Control Program here in Katsina. And so we see the advantage of using that avenue to detect and manage cases of Buruli ulcer. So active case search is also important, and reporting of the diseases. For those that do not present through this program, we need to actively look for them and report those diseases. And this active case search actually requires a lot of collaboration between the dermatologist and the plastic surgeons, because typically in most settings, chronic leg ulcers get referred to the plastic surgeons. So they may not even get to access, may not get to see the dermatologists, and the plastic surgeons, with all due respect and apology, may not actually think about some of these neglected tropical diseases. Their mind are more likely to be biased towards surgical causes of chronic wounds. So this requires a lot of collaboration between the plastic surgeons and the dermatologists. Proper wound care is also important. Cleaning the wound with normal saline, application of dressing, depending on the extent of the disease, patients may have semi-open or even closed dressing, and then early physiotherapy, especially for ulcers that are crossing the joints. Early physiotherapy is important to limit disability. And when you have a patient that has HIV and co-infection with Buruli ulcer, then special attention should be given to drug interactions. The complications of Buruli ulcers include that they can have secondary bacterial infection, they might have osteomyelitis, and functional disability may occur following healing of the disease. But about 1/3 of cases heal spontaneously without treatment. Now, they may heal without treatment, but a lot of them heal with deformities and disability. These are pictures courtesy of Up to Date that are showing some of the problems of a healed ulcer. But look at if we can see the shoulder of this patient up here, the patient had to undergo surgery. And this is the hand of another patient with Buruli ulcer. And look at the deformity, and likely there will be disability resulting from the positioning of his fingers. So this is actually what the whole discussion today is trying to prevent. We should be able to detect it early and also manage it to prevent this. So prevention includes the BCG vaccination seems to offer short-term protection. Studies were done, and BCG that is used for prevention of TB showed that it can offer some protection against Buruli ulcer, but maximum protection lasted for only about a year. So there's still more work ongoing on looking for a vaccine against Buruli ulcer, and wearing protective clothing, especially when working in swamps and around water bodies, may protect. Looking at the understanding and the knowledge that it's mostly around water bodies, so it may protect from contracting the disease. The most important thing is early recognition and management. That is what is key to limiting disability. These are my references, and thank you for listening.
Thank you so much, Dr. Abdullahi. Hello?
Thank you, Dr. Abdullahi. Thank you. So let me hand over to Dr. Gold and Dr. Oiwo to manage the Q&A session. Yeah.
Thank you so much, Dr. Cole, again for organizing this, the 4th session in this series of NTD meetings. And thank you, Dr. Abdullahi, a very lucid presentation as usual. So I have started answering some questions, and I've answered some of the questions. So if you can check in the Q&A section, you'll be able to see that I've answered some of the questions. So just a follow-up, Dr. Abdullahi, I've answered, there's Zaradin Bala Ibrahim says, how can you differentiate between tuberculosis and Buruli ulcer using AFB technique? And I already answered that AFB can be positive in both because they are both acid and alcohol fast, but clinically TB doesn't look like Buruli ulcer. And she went ahead to ask again, that which means diagnostically using microscopic results, you cannot differentiate between tuberculosis and Buruli ulcer. I was just about to answer that, but I will let you answer the question, Dr. Abdullahi.
All right, thank you very much.
Yeah, and the last question there by Ibrahim Yusuf. Oh no, go. Oh dear Lord, I'm so sorry. Dr. Abdul, I'm so sorry.
No problem.
So sorry. I went into the room and I did not lock the door, and these children came to find me here. Apologies, please. So you have 1 or 2 other questions there.
Yes,
so please, Dr. Abdullahi, the floor is yours. Thank you.
All right. Thank you very much, Mr. Zaharuddin Bala Ibrahim. The question is that, which means diagnostically using microscopic results, you cannot differentiate between tuberculosis and Buruli ulcer. if both Buruli ulcer and tuberculosis are caused by mycobacteria, mycobacteria generally are all acid-fast bacilli. So if it's to use AFB, one, to my knowledge, may not be able to differentiate between tuberculosis and Buruli ulcer using AFB. However, if you are to use histology, then Buruli of the tuberculosis actually gives you a granuloma that has caseous, central area of caseous necrosis. This is not what is described. There's a granuloma, but it doesn't have central area of caseous necrosis if one is to use histology. But using acid-fast bacilli, all of them are acid-fast, so one may not be able to differentiate. That is based on microscopic results. But from the history and clinical examination, a patient with tuberculosis may usually present with history of constitutional symptoms like fever, like weight loss, like anorexia, like lymphadenopathy. All of these are absent in patients that have Buruli ulcers. So using acid-fast bacilli, to my knowledge, no. I don't know whether there are medical lab scientists that may have more information than I do, but to my knowledge, all of them are acid-fast bacilli, no. But histology should be able to give you a difference. So that's for Mr. Zaharuddin Ibrahim. Anonymous attendees asking, has the link to the previous session been posted? There is a link to the YouTube videos. These videos, the recordings have been uploaded to YouTube, so a link has been posted. So you have the previous sessions, and this session will also be uploaded on YouTube. Then what are the clear differences between Buruli ulcer and differential diagnosis like cellulitis, diabetic foot ulcer, and lymphatic filariasis? So like I mentioned, it depends on the stage of the Buruli ulcer. If you get a patient with edematous Buruli ulcer, that is when when differentials like cellulitis and lymphatic filariasis come into play. And the major difference between them and Buruli ulcer will be the pain and also the other signs of inflammation that are usually not present in patients with Buruli ulcer. That is for the edematous stage. But please, let me be clear, and let me say this again. It is very rare and it is not common. So let us not be looking for patients that have a swollen limb as patients that have Buruli ulcer. The more common thing we have in our environment are nodules and ulceration. So while you want to have that as a possible, should be running through your mind, it is not the first thing that one should think about. But for diabetic foot ulcer and Buruli ulcer, usually the difference is that you have a patient that is already a non-diabetic in diabetic foot ulcer, and usually the ulcer will develop on the pressure-bearing areas of the leg. That's usually around the calcaneal region, around the head of the metatarsal bones, because those are the pressure areas. It is developing as a result of abnormalities in the nerve, what do you call it, neuropathy. But in patients that have Buruli ulcer, they usually present on the limbs, not underneath the foot, and they may or may not be diabetic. It's neither here nor there. But for diabetic foot ulcer, it presents in the setting of diabetes. Other differences might be the pain. Both diabetic foot ulcer and Buruli ulcer might actually not be painful, because once the nerves have been destroyed, patients with diabetes may not feel pain. But then once there is superadded bacterial infection, that might also be present. But they ultimately, these are the kind of patients that may benefit from taking swabs for PCR or for the acid-fast basis, because nothing stops a patient with diabetes from developing Buruli ulcer. So those are the patients that, while you may be treating for diabetic foot ulcer, nothing harms the patient by just running investigation. Then how can we access the presentation slides? Olarewaju Sunday, we've already mentioned that they are on YouTube and the link has been posted. And the link has actually been also sent to our emails. So please, let's check our emails. And when we see the notice from us, it may be about this link for watching the replay on YouTube. Fahad Lawal is asking that, please, can a wound gene expert be helpful? I didn't come across that as an investigation for Buruli ulcer. However, from my knowledge, even the gene expert, they are all nucleic acid-based investigations like PCR, and you need the particular cassette, or is it called cassette? No, I can't remember. Sorry, I think it's a cassette, or it's called I've forgotten the name for now. So you need the one for Buruli ulcers to be able to run the investigation. But the machine for gene expert may not be the one for Buruli ulcer, but they are all nucleic acid based investigations. Is rifampicin resistance documented like in MDR-TB? Again, I didn't come across that, but I'm sure that's a possibility, but I didn't come across that information, whether rifampicin resistance was documented in MDR-TB. Most of the emphasis for Buruli ulcer is even just to even be able to recognize it, to know how it's transmitted. So I don't know, but I've not come across any information regarding rifampicin resistance. Maybe if there's any contribution. Is it wound swab that will be used for the AFB test? Yes, you can swab the undermined edges of the ulcer, Zulfa, the undermined edges of the ulcer, and then make a smear on the glass slide and then subject it to an acid-fast test. You can also use a fine needle aspirate to make your swab. It all depends on what you have access to and what you're comfortable doing. Fahad is mentioning that the link for the Onchocerciasis lecture is not available on YouTube. We will rectify that soon. Thank you for that information. Thank you, Mr. Kenneth. It's called a cartridge. Thank you. It's called a cartridge.
Yeah,
so,
it's available now. If you go, I'm sorry,
okay.
I uploaded it late, but it's on YouTube now. If you go there, you will see it.
Okay, so Fahad, that's the link for the Onchocerciasis is on YouTube now. It has been uploaded. So if you go there, you will, what do you call it? You get it. Excellent presentation. Thank you, Mr. Pius. Please, could you share a contact database of dermatologists and plastic surgeons across the country? Okay, now, Mr. Pius, I don't have that information, and I doubt if we do. However, we have a Nigerian Association of Dermatology, and that Nigerian Association of Dermatology has a website, and on the website there is room for the dermatologists to actually register and have a profile which will also include their location, if they work in private or public setting, and all of that information. Unfortunately, not all of us. Let me just say that you can check there. Let's leave, but I'm not sure whether a lot of us have registered on that website. But what we usually do is once we know each other and we refer each other. But I think that most of the states in the Southwest have a dermatologist. At least I know in North Central, Plateau has, Kwara has, Abuja has, Nasarawa, yeah, they do. What I'm not sure of is Kogi and Benue. I'm not sure of those locations, but we have them in the Southwest. We have them some in the Northwest. Zamfara and Kebbi do not have. The other states have. In the Northeast, there is one in there. They have one in Borno, and I think in Adamawa. The other states don't. I don't know. I don't know of the other states. So I honestly do not know. But if you can send an email, if there is that database, maybe it can be gotten across to you. That's something that should be available. Some people have uploaded their profile on our NAD website, so you should be able to access that there. Then the next question is, what topical agents can be used to dress this ulcer? Then can it be transmitted by contact with the ulcer? That is from Sakinat Adebukola. The topical agents that I use, usually they use normal saline to clean the wound. And then I saw that you can use phenytoin powder and some things, but it's not as if they are standard guidelines that you use those things. But what you just do, what I saw was that you just use normal saline to clean, and then you can apply a petrolatum to plus or minus an antibiotic impregnated gauze. That is usually like sulfuratul or something to cover the wound. And then if there is need, you can add more layers after that. Otherwise, you can leave it like that. That was what I saw as the dressings for patients with Buruli ulcer. Now, can it be transmitted by contact with the ulcer? No. That's what I mentioned earlier, that human to human transmission is extremely rare. So they have no, even at that, I don't remember that it was about ulcer, contact with the ulcer. But notwithstanding, if one is handling an ulcer of such nature, one should observe universal basic precautions. But I didn't see that there were reports of this. Then pharmacist Oshine Motorayo is asking for you to address. I think it should be in our emails. And Dr. Cole mentioned at the beginning today that she will send it to the chat box. So maybe we should check the chat box, please. Anonymous attendees also asking the same thing. Anonymous attendees also asking that will there be CME points for this training so far? A big thank you to all the facilitators. Thank you very much. Yes, there will be CME points for the training. We are working on the logistics of that. That should come up at the end of the training. Okay. So Modupe Ologunaba, I hope I'm pronouncing it well. Meant okay, she was asking, are there tropical drugs available? Okay, Ologunaba, thank you, sir. Thank you. Are tropical drugs available for this disease condition? I didn't come across any. The recommendation is the rifampicin-based oral antibiotics, and then in certain instances, injectable antibiotics. Abimbola is asked, thanks so much. Thank you too for your thank you, and then kindly send display link to registration. We will do that. Okay. Can the ulcer be dressed with honey? I guess so. I didn't come across any studies on that, but from my knowledge, patients with diabetic foot ulcers can be, honey is used for dressing such patients. So I do not know that, I don't think, this is just extrapolation, that there's any contraindication to dressing with honey. However, maybe more studies need to be done. Honey has some advantages. It helps with regrowth and of the granulation tissue and healing of the ulcer. So maybe then that's an area for study. I don't know, but honey is used with chronic wound ulcers, and this is one of them. So there might be room for that. I honestly did not come across anything that said do it or don't do it. What I came across was the phenytoin powder that I mentioned earlier, and also use of thermotherapy. Just like cutaneous leishmaniasis, there are some patients that heat was applied as close to the ulcer as possible consecutively, and the patients actually did very well. But I didn't see honey per se. That is the last question. Okay, that's the last question. Thank you, Motorayo. Thank you. That's the last question.
Thank you, Dr. Abdullahi, for those quite straightforward answers. I want to thank our participants for the questions. It's quite a nice feedback after the few minutes of the lectures. And the array of questions actually shows the interest across various disciplines, as I can glean from where all those questions came from. And just some quick additions. Well, for rifampicin resistance, just like has been reported for TB and even leprosy, some works have started reporting rifampicin resistance, especially for rifampicin streptomycin combination and a few others. So again, quite some more work has still been done in the area of Buruli Ulcer, chemotherapy, pharmacovigilance, and all the target pillars towards the elimination of Buruli Ulcer. It's also good to know again that the efforts by the Nigerian Ministry of Health, that's the Federal Ministry of Health, towards the eradication of Buruli Ulcer, it's been strengthened. And if for those of us who are here, we can access our state NTD coordinators. Every state has a neglected tropical disease NTD coordinator. And specifically, we also have state TB, leprosy, and Buruli Ulcer coordinator. From the information that I have, I know some states have gotten quite some fantastic results, like Ondo State doing quite well in the area of Buruli Ulcer control, and all the data submissions and the program as well. So we can liaise with our state NTD coordinator, particularly the state TB, leprosy, Buruli Ulcer officers. Then to also state as well that the intent of this lecture is to help us pick Buruli Ulcer at that very early stage of that patient that comes to your hospital, to your clinic with a wound that has refused to resolve within a week or 2 weeks. We should begin to think beyond just, oh, it will go, and all of that. Then for those who we know in the villages, it's not a cost. Because again, like some works that have been done, Ukwaja had submitted, had reported a work that even almost quite a sizable amount of the participants in that study believe that NTDs, some of the NTDs are a curse from God. And so this is to also help enlighten, help us reach out to the populace on what needs to be done. And quite on some efforts in Nigeria, the graph as it were, in addition to what Dr. Abdullahi has mentioned, in Nigeria peaked in 2017. And by 2017, there were about 700 cases, annual cases, and 2020, about 150. But again, this is just to educate us and guide us on the steps to take in recognizing Buruli Ulcer, in seeking for help whenever they come to us, either as doctors, as nurses, as pharmacists, as community health extension workers, any area, any discipline where you work, the ability to link patient to the appropriate next step of intervention whenever we see them is the purpose for this presentation. So I want to thank Dr. Abdullahi for the very lucid presentation. I want to thank our audience as well. Thank you so much. Dr. Cole, over to you.
Yes, thank you very much, Dr. Oiwo, for that. Thank you, Dr. Abdullahi, for the wonderful presentation, and for Dr. Gold Olufadi, who has helped us to answer most of the questions online, and then Dr. Nafisa completed. So if you check the webinar chat box, I have copied the links for the Onchocerciasis webinar, which was 2 weeks ago, and then the registration link for those who are yet to register formally for the webinar series. So you can actually get both links from the chat currently. So I'll just leave that on for a bit. I don't know if anyone else has any other questions. We still have some time. We finished quite early today, so maybe we can enable some of the participants, if you want to share an experience or you have any further questions, you can actually raise your hands and we'll just enable you to speak and share. Okay.
Yeah, Dr. Koiva may come in.
Yes, please.
I know Dr. Olufemi, I know, is on this call, on this webinar, is the state TB, leprosy, Buruli Ulcer program officer in Ondo State. So maybe he could share with us some of their success stories. I know they had the best states last year. So you can share with us their success story since he's here with us. Dr. Femi, I know.
Okay, Dr. Femi, I know I'm going to enable you to be a panelist, sir, so that you can come on, and we'd love to hear your experience, because we would like, is he still on the call? Okay, I've seen him, so I'm going to make you a panelist so that you can share your wealth of experience with Buruli Ulcer. I think we can actually make a lot of progress with this particular NTD once more people are aware of it and we think about it. Thank you, sir.
Can you hear
You're
me?
welcome. Yes, we can hear you very well.
Okay, thank you very much. Let me appreciate everybody who joined in making this a success and who brought all of this. My apologies, I joined quite late, but of course, Buruli also is part of our three cardinal diseases that we control in the Ondo State Tuberculosis, Leprosy, and Buruli Ulcer Control Program. Just like Dr. Oiwo has said earlier, I deposited, we, for the first time in 6 years, we were able to identify our first 2-3 cases last year. And of course, the last time we diagnosed Buruli Ulcer before then was like 6 years ago. And so I can say that we've been able to at least move up again to the point of identifying patients. The third patient out of the first and second that we had, they were of course in 2 different local governments in Ondo State. Funny enough, not fully riverine, but the patients had a history of having traveled to some water-bodied areas, some riverine areas, and of course, over time, had the wound that was non-healing. It was like a non-healing ulcer. Specifically, the third patients that we saw had used all sorts of things, had gone everywhere. Skin grafting had been done. It kept breaking down, and of course, by the time we saw, well, even the ulcer was not exactly the kind of ulcer you'd have expected. Nowhere to actually, not undermining where we could actually stick in the examination or the investigation stick or so we're not exactly able to take sample the way we wanted to. But funny enough, we're still able to go around the ulcer. We're still able to pick a few something to at least send in for PCR, and at the same time we had AFB done. So the AFB was positive, and we're waiting for PCR just to be sure that we confirm. And by the time the results came out, it was positive. And so we started the patient on the appropriate medications. I can tell you that the patient is doing very, very, very well. In fact, they sent me some bit of congratulatory messages from the family, thanking us for the fact that we didn't allow them go in for another 3, 4, 5 sessions of skin grafting where they are done in Ife and some other parts. So basically, I think what I just want to share is once you get the diagnosis of Buruli ulcer and patients begin medication, it's like a wonder. It's a game changer. And by the first month, second month, patient is already looking like it's like you lied that it wasn't an ulcer. So I want to thank you for bringing this. I want to thank you because we know that indeed there's Buruli ulcer, and we have some cases in Ondo State, and we are even looking for more. We have also reported many cases of leprosy, and so we do look for both, even as we go in to continue our control program. Once again, thank you. We're available for talks. Anybody within the Ondo State axis, FMC or and of course within the Akure metropolis, the state control program is available, and we will partner and do what is needful. Thank you so very much.
Yeah, thank you so much, Dr. Aino, for sharing your knowledge and your experience on this. May I ask, did you also send your sample to Anambra State like we had for Katsina?
Yes, we did for PCR. Yes, we did.
Okay. Oh, thank you. Thank you so much for that.
Sorry, let me ask Dr. Ayo, please, because the Katsina experience was not funny. After they sent the sample took 6 days to arrive at Anambra, and then they said there was a sit at home or something like that, and then the samples eventually had to be discarded because they couldn't analyze them. So did they get the results from Anambra?
Yes, we got results. One thing we do with GLRA is the fact that somehow, because of the fact that we've not been reporting cases in a long time, a lot of states, Katsina and a lot of south states have had a lot of cases of Buruli ulcer. So for us, it was like one single sample sent must be guarded jealously.
Yes.
Exactly. So we made sure that result came out, and we got
okay.
Okay, thank you very much, Dr. Aino. Just to also add that Dr. Aino is a member of the National Committee on NTD for the Nigerian Medical Association. Thank you so much, sir.
Thank you for having me. Thank you always.
I think we also have some questions on in the Q&A section. I'm reading a comment on a man who is boasting of poisoning people with Buruli Ulcer, and the person who asked the question was seeking for the needed approach in this area. Well, I think that since we have heard of this, I think, sir, the person that asked the question should kindly link up with the state team, and I'm sure they'll be able to get across to the man two ways. Well, to an extent that the threats can be managed through the appropriate legal means. And two, I think the direction of the question was also to look at, is it possible the person is harboring the Mycobacterium ulcerans? So whatever that is, there are appropriate steps that need to be taken, which I think should start by reaching out to the state TB, leprosy, Buruli Ulcer program officer in that area. I think there are also a few other questions which I saw Dr. Abdullahi was already answering. Can Buruli ulcer be transmitted by mosquito bites? Well, like Dr. Abdullahi had mentioned, the transmission is still being investigated. So there are quite a lot of misconceptions about some of these neglected tropical diseases. Just like someone mentioned, scabies. Some people believe scabies is related to being dirty and all of that. But I'm sure that we have a week to talk on scabic, and we'll be able to look at that. So quite a lot of misconceptions, which I believe would be appropriately handled. So the pathogen, the transmission pattern is being looked at the moment. It's still a subject of research, as it were, for now. Honey, use of honey. Well, people are the cross-cutting approach to the management of NTDs in linkage with the Kigali Declaration, which is the latest inter-country declaration for NTDs, allows cross-cutting approach in which professionals break the silos of knowledge. So if this tends to work and is published and is reproducible scientifically, why not? If not, there are results there. I don't know if there are any other comments that are yet to be taken care of. Over to you, Dr. Cole.
Yes, I think I enabled Ibikunle Ashim. Raised your hand that you wanted to contribute. Maybe you can just speak now. I think you can unmute. Are you there? Okay, not really saying anything. Is anyone else raising their hands? Pious Sunday, would you like to say something?
Okay, thank you and good evening, everybody. I just wanted to make a comment with regards to the aspects that somebody mentioned about the use of honey for the treatment of ulcer. I had, when that was mentioned, I just dropped a message on the Q&A that my organization, the Leprosy Mission Nigeria, we are actually currently running a research which we call the honey experiment on leprosy ulcer. It's actually a randomized controlled trial of raw, unadulterated African honey for ulcer healing. And it's actually meant to evaluate the healing properties of using raw, unadulterated honey in comparison with normal saline in the dressing of leprosy ulcers. And we're actually conducting this study in collaboration with the National Institute of Health and Research, as well as with University of Birmingham in UK and University of Ibadan. So that study is currently ongoing. And I just wanted to just mention that.
Okay, thank you very much. That's very, very useful information, because we always want solutions that can be applicable and available in our environment, because honey would be, if found to be useful, something that probably would be easily accessible and would help with wound healing. So we'll look out for the publication, for that study. Thank you. So
Thank you.
I think there's no one else signifying to speak. So in the absence of any other questions or comments, we can call it a day. Dr. Gold-Olufadi, maybe you can do us the honors of closing the session for today.
Thank you, Dr. Cole. It has been an interesting session, and Dr. Abdullahi for that very lucid presentation. So next week we're going to, next week or 2 weeks time, Dr. Cole? I can't. Are we having the next one
it should
next
be
week?
in 2 weeks. In 2 weeks time. That should be on the 26th. 26th of March. Yes.
Okay, so in 2 weeks again, we hope to convene for another session of the NTDs lecture. So you can catch up on all the old lectures on the YouTube channel. And so we'll see you in the next 2 weeks. Thank you so much, everybody. Have a lovely week.
All right, have a nice day, everyone. Thank you for coming.
Yeah. Dr. Abdullahi.
Yes,
Sana?
ma'am.
Yeah.
Now we need.
Hello.
Thank you. Thank you, everyone. And
all right, bye.
have a lovely day.
All right.
Okay. I'm
Yeah,
just
Dr.
going to
Cole.
take
Thank
yeah.
you.
Yeah, bye everyone.
Bye.
Dr. Abdullah, yeah,